carrying out various academic programs, including this program. Dr. Pareek sir,
Thank
I
you.
request you
Thank
to
you,
say
dear
few
Dr.
words.
Keswani.
Thank you.
Really a great pleasure and honor to welcome all of you to this 8th base case discussion series of lectures on the platform of RSSDI Rajasthan chapter. And at the outset, I must extend my sincere thanks to Dr. Prakash Keswani, who is the convener of these case-based discussion series of lectures. And because of him, because of his hard work and constant work, we are unable to disseminate the knowledge to almost everyone in the Rajasthan, even outside Rajasthan also. So this is a very good way of disseminating knowledge to our friends and colleagues who are even at a village level or a small town. And so thank you so much, Dr. Prakash, for an excellent work and dedication work for all of us. I would like to extend most warm welcome to our president, Dr. Girish Mathur, who is brainchild. These series are his brainchild, and these one of the person who has taken RSSDI Rajasthan chapter to a great heights. I also would like to extend my warm welcome to Dr. Ramchandani, who is a very energetic, very dedicated honorary secretary of Rajasthan chapter, all the time available for everyone who has got any problem. Today we have got a very important lecture by Dr. Manglunia, a very young endocrinologist, very upcoming and young energetic endocrinologist, will be presenting the case, and we have got panelists, very learned, eminent panelists, Dr. Arvind Gupta, past president RSSDI Rajasthan chapter, Dr. Dariya, and Dr. Saxena, Rajnish Saxena, who will be discussing the case and will be presenting, having an active discussion with the case. So thank you very much, and thank you all the delegates who are attending today's program for sparing your valuable time. And I think because of the presence of delegates, we can make this conference, the CME program, a very successful. Thank you so much, Dr. Keswani, again for
Thank you, sir.
this opportunity. Thank you.
Thank you, sir. Thank you very much for your kind words. Now I will request Dr. Girish Mathur, sir. He is the most dynamic leader of the API national level, and he has taken our Rajasthan RSSDI to the heights. And this series of case-based discussion were started with his inspiration only. And I will request Dr. Girish Mathur, sir, to say few words, please, for us.
Thank you, Prakash. Am I audible?
Yes, sir. Yes, sir. Yes, sir. Audible, sir.
It's my profound privilege, pleasure, and honor to extend a warm greetings to all of you and to welcome you all on this 8th session of case-based discussion organized by RSSDI Rajasthan chapter. We are blessed by the inspiring presence of our mentor, Dr. K K Pareek. We are privileged and fortunate to receive his blessings, support, and help in all our academic endeavors. I'm also grateful to Dr. Prakash Keswani, the man behind this program, for his tireless efforts in planning and executing this program. We are getting excellent feedback on this program of case-based discussion. I'm also grateful to our dynamic secretary, Dr. G D Ramchandani, for all his help. I welcome today's speaker, Dr. Ankit, a young diabetologist from Saket Hospital, Jaipur, our esteemed panelist, Dr. Arvind Gupta, a renowned diabetologist, not only from Rajasthan, but over the country. Dr. S S Dariya, consultant physician, SMS Hospital, Jaipur, and Dr. Rajnish Saxena, diabetologist from Ajmer. I'm sure we are going to witness a very exciting and very enlightening discussion on diabetes cases. I extend my very best wishes for the success of the program. Thank you so much.
Thank you, sir. Thank you for your kind words. Your words have been always inspiring to all of us. Now we start our scientific program, and I request Dr. Ankit Manglunia to please start your presentation.
Sir, before
Yes.
you start the Ankit, I think what we will do in the series, the case discussion, when he will present his case, we will stop for some time. We will have some question and answer, and then we will go further. Ankit, it is
In
okay?
between also, yes.
Yes, sir, no problem, sir.
Yeah. After your case presentation, we'll have a little question and answer, and then you can speak further. Okay?
Okay, sir. Okay, sir.
डायग्नोसिस के पहले ही आपको डिस्कशन कर लेंगे थोड़ा सा.
हाँ जी, बिल्कुल.
Yeah, please go ahead.
I hope my screen is visible, right?
Yes,
Yes,
visible and
very good.
audible both.
Okay. Thank you, sir, for the opportunity. I am going to present this case as I saw the patient and how I proceeded over the period of a week in this patient. I am going to present this in the similar manner. So this is a 60-year-old male who is a resident of Sikar. He came to me with a history of diabetes for 10 years. He is a known case of chronic kidney disease since 4 years and on maintenance dialysis since last 3 years. Hypertensive since last 4 years and hypothyroidism since last 4 months. The patient basically presented to me with complaints of increased acidity since last 2 years, polydipsia in the form of dry mouth since last 1 year, generalized weakness that is not able to get up from sitting posture since last 1 month, constipation and pain over both the legs since last 1 month. So coming to the history of presenting illness, the patient has this complaints of excessive burping and abdominal bloating, which was aggravated after taking food, and it was associated with burning sensation since last 2 years. And over the period of these 2 years, the frequency is being increasing day by day. It is not even relieved after taking antacids or even PPI medications. It is oftenly associated with nausea, but it does not have any complaints of vomiting. Over the last 1 year, patient is feeling dryness of mouth throughout the day. He keeps on taking sips of water, 3 or 4 sips of water every 5 to 10 minutes. And it has become so excessive that despite having CKD, he takes almost 3 liters of water a day. He does not have any complaints of polyphagia. Patient also complains of generalized weakness since last 1 year, but since last 1 month, he is feeling pain over his both the thighs. He is not able to get up from sitting posture or climb stairs. He requires support to get up or to sit, but once he gets up, he is able to move around with slight support. He does not have similar complaints in his upper limbs. He also complains of tingling sensation over both the legs, which is associated with pain, and it gets worse at night. There is no complaints of numbness, paresthesia over the legs. There is no history of any slippage of sleepers while walking or feeling of the floor as a cotton wool. Patient is also experiencing constipation since last 1 month to an extent that he is not able to get fresh for 2 to 3 days. It is not relieved even after taking laxative, and constipation has been so severe that patient had taken enema 5 times in the last 1 month. It is not associated with any alternating diarrhea. Coming to the diabetes history, now the patient is the known case of diabetes since 10 years. When he initially had presented 10 years back, he had complaints of fatigue and there was balanitis. At the initial presentation, his fasting plasma glucose was 240 and postprandial was 320 and A1C was recorded as 10.3%. There was no renal function done at that time of the initial diagnosis. Then patient was started on 2 mg glimepiride and metformin 500, which he was given twice daily. After 2 weeks of taking the therapy, the plasma glucose level basically normalized. Fasting was 104, postprandial was 140. Then patient became non-compliant with the medications. He stopped his dietary restrictions as well. He was taking medications on and off. After 2 months of the therapy, patient developed level 2 hypoglycemia. The plasma glucose level was not documented that time, but patient had neuroglycopenic symptoms, and after taking sweets, the hypoglycemia basically relieved. So patient reduced his dose from twice daily to once daily. But again, he was infrequent in taking the medications. He was not monitoring his blood glucose levels also. And after a period of 3 years, patient completely stopped taking the medications.
Ankit, just
Then,
Ankit,
yes, sir.
just what is level 2 hypoglycemia? थोड़ा सा सबको explain हो जाएगा.
Sir, there are 3 levels of hypoglycemia: level 1, level 2, and level 3. Level 1 is basically mild form of hypoglycemia, in which patient might have few symptoms with blood sugar, blood plasma glucose levels is less than 70 but more than 54. In level 2 hypoglycemia, it is moderate, in which the plasma glucose level is less than 54. Patient is having neuroglycopenic symptoms, but he can self-medicate himself. He can take, he is able to take sweets or something so that the hypoglycemia is relieved. And in level 3 hypoglycemia, patient requires assistance of some other person. He is not able to take something on his own.
And also hospitalization is required, usually level 3.
So might be depending on what the underlying cause. If you say CKD or he has taken very high doses, and if we are predicting he might develop hypoglycemia again and again, then he might require hospitalization.
Okay, thank you.
So 2 years later, that is after 5 years of diagnosis of type 2 diabetes, then patient visited his local physician again with the complaints of swelling over the face and legs. He had weight loss and there was generalized fatigue. At that time on evaluation, his fasting was 280, postprandial was 359, and HbA1c was 13.4%. His creatinine has increased to 3.2 and hemoglobin was 18. He was again started on glimepiride 2 mg and metformin 500 twice daily. But patient had frequent episodes of hypoglycemia on this regimen. Over the period of 1 year, he developed 2 episodes of very severe hypoglycemia, for which he was admitted also. Gradually, he reduced the dose to once daily, then half of the tablet was given for a day, and later on it was completely stopped when he developed ESRD. So in total, after 6 years of diagnosis, patient presented with complaints of breathlessness and altered sensorium. That time his creatinine was 11.2 and he had very severe acidosis. Since then, patient is on maintenance hemodialysis twice a week. After developing this ESRD, patient fasting plasma glucose was 116 and postprandial was 162 without any medications. But after starting dialysis for 6 months, patient started having complaints of dryness of mouth. Then his fasting and postprandial plasma glucose were on the higher side, and he was started on 3 units of regular insulin before breakfast and before lunch. So now over this period of last 3.5 to 4 years, despite taking regular insulin, patient's plasma glucose was progressively rising and he did not develop any hypoglycemia. Since last 2 years, patient was on regular insulin of 40 units pre-feed and glargine 30 units at bedtime. Even then, his plasma glucose levels were uncontrolled. Since last 3 years, patient is anuric. He rarely passes urine of 10 to 20 ml over a period of 1 week or something. There is complaint of dryness of mouth, for which he is taking more than 3 liters of water a day. And because of taking so much excess of water, the dialysis had to be done 3 times in a week since last 2.5 years. Occasionally, if he gains more than 4 kgs of weight in a day by drinking water, then dialysis has to be done on a continuous basis as well. So coming on to the insulin history now, the patient was taking insulin over the abdomen and thigh. There was proper technique, proper rotation, proper changing of needles is there. There is no lipoatrophy or hypertrophy at the insulin site. Patient collects his disposable needles in a box and he used to dispose them at his dialysis center. And over this period of last 2 to 3 years, he has been exposed to different forms of insulin, whether it is glargine 100 units, 300 units. regular insulin of different brands, even analog insulin that he has taken. But despite that, his plasma glucose levels were never under control. Coming on to the family history, there was no history of diabetes in the family, no history of coronary artery disease, chronic kidney disease, thyroid, or other autoimmune disorder in the family. So at the present moment, when patient presented to me, he was on human actrapid 3 times a day, injection degludec 45 units, tablet linagliptin 5 milligram once a day, levothyroxine 37.5 microgram once a day, leveramar 400 milligram twice a day, sodium bicarbonate tablets 500 milligram twice a day, active calcitriol 0.25 microgram once a day, Nicardia 200 milligrams 3 times, and erythropoietin 10,000 units once a week. So should I proceed to examination?
Because you don't think that very high doses of insulin are required. Earlier, he was requiring very low doses of oral anti-diabetics, and again, he was developing hypoglycemia.
Answer, he was requiring such high unit despite having end-stage renal disease, sir.
Yes, sir.
So
yeah,
that was the
one more
thing.
Yeah, one more thing, when he presented and the second time, I think after the hyperglycemia developed again, and his creatinine was 3.2. At
Yes,
that
sir.
time, glimepiride and metformin was given twice a day.
Was given, sir. Twice a day, yes, sir.
Yeah, so I think, Dr. Daria, what do you think?
I think that time the treatment was not proper, because if somebody's already creatinine was 3.2 and they have started the glimepiride 2 mg with the metformin.
To
So again
4
that,
milligram.
yeah, again that is why he developed the hypoglycemia.
Yes.
So I think the DKD has started from that time only. If the proper treatment could have started that time, I think he will not take too much of this insulin.
Yeah, Shailesh, Dr. Shailesh.
Yes, sir. So this patient had extremely high sensitivity to sulfonylureas. With just half tablet or 2 milligram, he had severe hypoglycemia. So we could have tried some other sulfonylureas, other oral hypoglycemic agent like ripaglinide. Why ripaglinide was not used when it is quite safe in renal compromised patient?
And linagliptin also, sir.
And he was given metformin twice a day, 500 milligram twice a day, when the creatinine was 3.2. eGFR was not done.
Yeah.
So I think this is the lesson for all of us.
Sir,
Yes, sir.
the day one when he diagnosed 10 years back as a diabetes, I think being a diabetologist, we all should follow the investigation protocol.
Was not done.
So investigation protocol, we should start that time with all the LFT, RFT. If that time the RFT is normal, I don't think so that he will develop within 4 years of that DKD. So at the time of diagnosis, we should go for a LFT, RFT, lipid profile, the HbA1c, the urine routine, this USG whole abdomen to see the kidney size, and then the fundus at the time of diagnosis. And then again, all these things have to be repeated once, at least once a year, once in a year.
Sir, at the time of diagnosis, if we follow the RSDI wheel, then we can save the patient. We can prevent all the comorbid conditions.
Yeah.
No, actually, on the when he developed first hypoglycemic episode, it may also be possible that at that time also the creatinine may be high.
Yes.
He
Yes,
must have been
definitely, sir.
suffering
Yes.
from CKD, and that's why he developed hypoglycemia.
Yes, that is also a possibility, sir.
So detailed kidney examination should have been done at that time when he developed the severe hypoglycemia. Yes.
And he was never been put on aspirin or statins. When we know that even when you are diagnosed for the first time for diabetes, the process of atherosclerosis starts much earlier before you diagnose a patient with diabetes.
Yes, sir. The
Yes.
time of diagnosis already sets in.
So antiplatelet therapy must have been given from the very beginning for primary prevention.
Yes.
Uh,
Yeah.
One more point, sir.
Yeah.
because this patient developed CKD quite early in the diabetic condition. We don't know exactly whether it was pre-existing from what duration. But
Right.
still, if we presume that diabetes is not very old, then development of CKD too early, we should have looked for some other non-diabetic renal causes of non-diabetic kidney disease, which
Like
may be
hypertension also simultaneously he had hypertension.
Absolutely.
Yeah.
Dr.
Sir,
Shailesh, I
hypertension
think
he
this is the
developed
catch.
after having CKD.
Yes, I think Dr. Shailesh has the point that at that particular time we should have thought of non-diabetic renal disease also.
Yes, sir.
So
Yeah.
what is the lesson that every patient which comes to you, whether for diabetes or for hypertension, we must get everything lipid, blood pressure monitoring and everything, every investigation to be done at the first instance.
And sir,
Yes, sir.
fundus examination was actually that was the real catch also. As Dr. Shailesh had told, when the CKD was there, serum creatinine was high. I think fundus examination should have added the
Should have been
diagnosis.
done.
And the urinary microalbumin is really a very cost-effective test.
Very rightly.
We can
That's why I
find out
told you, no,
the
sir.
development of CKD or renal nephropathy in very early stages,
Yes.
which we usually do not go for all patients at the time of diagnosis.
These days we should do the urinary albumin creatinine ratio. That is a must.
Sir.
sort of
Yes,
thing.
sir. UACR.
That is why I said we should follow that protocol, starting with the LFT, RFT, lipid, USG, the urine, the fundus, the ECG, even ECG in each and every
ECG
patient
is a must.
at the
It's a
time
must.
of diagnosis, and once in a year, every year. I think we can catch early.
Yes.
Yes.
No, Dr. Loda, my one question. Should he been started on antiplatelet therapy for primary prevention? Is there any need without knowing the risk for cardiovascular disease?
No, sir, that is not
No.
recommendation by AD also.
So cardiologists definitely, and no, even ESC guidelines say that primary prevention by antiplatelet drugs are not even required.
Yes, no, there is a one of the guidelines that with discussion with the patient, you can start for aspirin or antiplatelet therapy for primary prevention also. Because these patients are a great risk for development of cardiovascular disease.
So the patient who have cardiovascular risk, which includes patient has any evidence of ischemic heart disease or very high cardiovascular risk factors or family history of strong family history of ischemic heart disease, all those patients, or with that dyslipidemia, or even type 1 diabetic who have diabetes for more than 10 years.
Yeah.
And risk factors for cardiovascular disease is there. These are the indications by the ADA, sir.
Yeah. Dr. Shailesh.
CKD patients, they already have deranged blood coagulation parameters, and they have more chances of GI bleed. So I think unless there is a compelling reason to start antiplatelet, we should avoid them, because these patients, they bleed from GI and they have impaired coagulation parameters.
Every patient of CKD is at a great risk for development of cardiovascular disease.
Yes, sir.
Yes,
It
sir.
is
That is
almost
true, sir.
equivalent. CKD is equivalent to cardio CVD. So how can we not prescribe antiplatelet therapy?
But sir, primary
I think
prevention
it
doesn't
must
help
be-
actually.
I think we must discuss with the patient with pros and cons for side effects. If he is ready when we ask him, I think it should be a must.
So 2-3 trials are there. Some studies are there recently published also that they say that until unless Dr. Prakash has given the indication, if those indication of high family history, the ischemic heart disease or something event is there, and until and unless that thing, I think primary prevention is not very helpful.
We all know that
So
all
those
diabetic
trials have
patients die
suggested
because of cardiovascular disease. 90% of patients die because of cardiovascular disease.
Yes, sir.
So I think I have seen in ADA that after discussing with the patient, one can start for even for primary prevention. Secondary prevention we must give.
Yes. No doubt in this. Yeah, Dr. Ankit,
Okay.
can go forward?
Yes, sir. So in examination, I will talk about the positive findings. On
Yes.
vitals, patient was having blood pressure of 160/90 in supine position. There was no postural fall in blood pressure. The pulse rate was 78. Pallor was present. No cyanosis, clubbing, edema, lymphadenopathy or icterus was there. His BMI was 28.1 and his ankle brachial index was 1.3. On general examination, his tongue was dry and coated. There was no oral thrush or any features of periodontitis. No acanthosis nigricans. Skin was dry. There was dry eyes. No features suggestive of Cushing's or acromegaly. But I was looking for the signs of any other hormonal disorders like Cushing's or acromegaly, which could cause this uncontrolled hyperglycemia. Insulin injection sites were normal. There was no lipoatrophy or hypertrophy seen. On neurological examination, cranial nerve examination was all normal. In the fundus examination, in right eye, there was mild non-proliferative diabetic retinopathy. In motor system examination, the patient has the bulkiness of the muscle mass over the left thigh was slightly reduced as compared to the right thigh. Power at the hip joint over the right side was 4+/5, whereas over the left side it was 4/5. And at rest, all the joints it was normal. Plantars were bilaterally flexors, and deep tendon reflex, ankle reflex were absent bilaterally. Knee reflex was slightly reduced, and over the upper limbs, the deep tendon reflexes were normal. In sensory system, vibration sense was absent up to the knee. It was present at the iliac crest. There was definitive reduction in the fine touch and pinprick sensation. Temperature sensation was preserved. No cerebral signs. The cardiovascular respiratory GI system was absolutely normal. Musculoskeletal system examination was also normal. So to summarize my case, he was a 60-year-old mild obese male with 10 years history of type 2 diabetes, presented with poor glycemic control on basal bolus regimen with complaints of polydipsia, gastric discomfort and proximal muscle weakness. He had a background history of hypertension and stage renal disease on maintenance dialysis 3 times a week and subclinical hypothyroidism. On evaluation, patient had mild pallor with distal symmetric polyneuropathy and asymmetric diabetic amyotrophy, mild right eye non-proliferative diabetic retinopathy without any evidence of macrovascular complications.
Okay, okay. Dr. Rajnish, what do you think? Okay, this is the provisional diagnosis. So,
Which after the history and examination, this
Yeah.
was my provisional diagnosis, which I
Yeah.
kept.
I think, Ankit, we can add in this that patient is complaining again and again constipation. So I think there may be a diabetic complication of that gastroparesis also you can include in that.
Yes, sir.
Yes, it
Doctor-
can be.
Dr. Rajnish, what do you think? Is it okay? Dr. Rajnish, you are there?
Yes, sir. So neuropathy is also present there. And secondly, ABI is 1.31. It indicates that calcified blood vessels are there. So involvement
Yes, sir.
peripheral arterial disease is also there.
Okay. So what is your planning in this uncontrolled diabetes?
But I think if there is a the peripheral arterial disease are included, then sir is right. We should start for the CAD also, no? Macrovascular, both complications are there. There is a NPDR is there. Your ESRD is there. Hypertension already, amyotropic, the uremic myopathy.
Sir,
So-
Dr. Dariya, the question
but
here is
for
now
peripheral-
uncontrolled diabetes.
Okay.
In spite of very high doses of insulin, patient is still uncontrolled diabetes. So now I think first focus is on the control of diabetes. And what do you think, Dr. Prakash, Dr. Shailesh?
Yes,
So
this is
this
a
was
matter of
insulin.
worry that around 200 units of insulin is still uncontrolled.
Yes.
In spite of end-stage renal disease, where low doses of the insulin are sufficient to control diabetes. So we must try to find it out whether the patient has myopathy also, whether he has some other endocrinopathy. As we last time discussed, there was a Cushing's or acromegaly or some other factor which is causing increase of blood sugar. or some other factor which is causing decreased action of the insulin. So
Yes,
these all work up should be done in this patient.
and in spite of the chronic kidney disease or DKD, the requirement of insulin was very high. Dr. Shailesh?
Yes, sir. I think Ankit mentioned 2 or 3 times that there is persistent dryness of mouth and dryness of eyes also he mentioned. So I
Yes.
think we should suspect some autoimmune diseases like Sjogren syndrome, which can secondarily involve kidneys also. So we should keep this thing also mind, although this is quite rare, but I think there is a possibility.
Yes, definitely.
Absolutely, absolutely. I think you have already given the clue for that. Dr. Ankit,
Yes, sir.
please.
Sir, so this was the scenario 10 days back when he first presented to me. The patient was undergoing dialysis. He was having hypotensive episodes at that time, and dialysis had to be terminated prematurely at 1.5 to 2 hours. And so he was undergoing dialysis over the period of 10 days continuously. He was not taking any hypertensive medications that time. His blood pressure, despite without any hypertensive medications, was 150 by 86. His plasma glucose level was more than 600 on the glucometer. He had increased his dosage to 60 units pre-meals of regular insulins. And patient had started IV insulin by syringe pump at his home for last 3 days. And he was taking insulin at 8 to 10 units per hour at his home only. Despite that, his glucose level varied from 300 to high in the glucometer. At this moment, he presented to me when I examined the patient.
Okay. So, yeah.
Yes, sir.
So I think this is something which I think very rare thing, that in spite of the very high doses of insulin, severe insulin resistance sort of thing is there. Now 2 questions are already there. Can we answer? The one is known as relative hypoglycemia. Another, Dr. Geeta Arora asked about the electrolytes. Why the electrolytes were not done?
Sir, I am just presenting the examination part.
Yeah,
Now I
yeah.
am coming to the.
Okay, please.
This is how I'll just talk about them, sir, right now.
Okay.
So this was the scenario at the time he entered my clinic. So when he arrived to my hospital, the random plasma glucose level was 892. He came. So I started him on insulin infusion, and I started on analog insulins at a rate of 20 units per hour. Despite giving 20 units per hour, even for few hours, his glucose level remained more than 500. Gradually, the infusion rate was increased by 30 to 40 units per hour also. And this high level of insulin was almost given for 60 hours in this patient, and his glucose level varied from 200 to 500. And because, as Shailesh sir said, there was suspected of some underlying autoimmune disorder as well, I had sent C-peptide levels. Despite the glucotoxicity, C-peptide level was sent and insulin antibody level were sent. I also wanted to send the insulin receptor antibodies in this case, but that is not available in our country. So this is the baseline investigation that patient has presented to me with. There was slight anemia with hemoglobin of 10.7. His albumin was fairly okay, 3.6. Creatinine was 6.4. The sodium was 117. The corrected would be around 131. The potassium was 6.9. HbA1c was 10.4%. Triglyceride level was 109. And ESR was 113. In the arterial blood gas analysis, there was mild acidosis with bicarbonate level of 17.4. The calcium level was 9.6, phosphorus was increased 8.8, and intact PTH was 298. CPK levels were also done, it was 233, just mildly raised. So this is basically the upper part of the graph. I'll just add this pointer to this. This is the glucose values of the patient.
Thank you.
Yes, sir. So the upper line is the glucose values of the patient. This 650 is not the figure, it is just to show in the graph. It is more than 600. In the glucometer, it always comes high. So these are more than 600 values. And lower graph is the insulin doses which was given. So at the time of dialysis, there was decline in the plasma glucose levels and also the insulin requirement. But as soon as dialysis is over, again there is progressive rise in plasma glucose level despite patient is taking orally or not, and there is progressive rise in insulin levels as well. So this was the day 2 graph. This was the day 3 graph. On the third day, he was not on dialysis at all. The plasma glucose level remained above 450 throughout the day, despite increasing my dosing to 50 units per hour. So now my C-peptide and insulin antibody levels came. The C-peptide levels were high, 8.98, and this level was sent when the plasma glucose level was 892, despite having so much glucotoxicity and 10 years of diagnosis of type 2 diabetes. Insulin antibody levels were positive. So I went ahead with the literature, what is there. I had also gone for the autoimmune disorders. I was suspecting Sjogren's syndrome in this patient. I did anti-nuclear antibodies, it came out to be negative, and immunoblot method was done to look for other markers, and I found marker for scleroderma to be positive, which was significant +2 levels in this patient, but Sjogren's was negative. So because of this underlying autoimmune disorder and the literature that I searched for, I started patient on methylprednisolone 1 gram after the dialysis. So after giving the methylprednisolone to the patient after 2 p.m. when his blood sugar level was 450, there was progressive decline in the plasma glucose level. It came down to 162 and I had to stop insulin levels at that time. After some time, again, there was progressive rise in the plasma glucose level, but my insulin requirement now was on the lower side. It was almost around 10 to 20. Earlier, it went to 40 to 50 units.
Yeah,
The
Dr.
next day,
yeah, just I think at this point of time, because now the things are actually now becomes very clear. So before that, you are giving the progress of the patient. I think let us discuss about the Sjogren's system, because you have thought of autoimmune disorders. And Dr. Shailesh also initially told when the CKD was there and it was not controlled, he also had the clue that some autoimmune disorders are there. So let us discuss a little bit of the Sjogren's system and the Sjogren's syndrome and the scleroderma. So what is the real Sjogren's system, the syndrome?
so the patient only had dryness
Yes.
of mouth and dry
Yes.
eyes. Initially, we thought it could be because of uncontrolled hyperglycemia.
Yeah.
He might be having polydipsia. He is anuric, so there is no history of any polyuria for the patient. And when I underwent with the literature after seeing the C-peptide and insulin antibody,
Yes.
so there were case reports with positive insulin antibodies and underlying autoimmune disorder.
Yeah,
So
and
that
I think, yeah, Sjogren's system, I think what I understand is that it is a autoimmune disorder of the salivary glands specifically, and that's why the patient develops the dryness of the mouth as well as the dry skin also. And then you have given one very important clue. In spite of polydipsia, patient did not have any polyphagia. So I think,
polyphagia, yes, sir.
yeah, there was no polyphagia, only polydipsia was there. So dryness of mouth with dryness of skin, that actually gives the clue that it is an autoimmune disorder of the salivary, usually salivary gland. So what I understand, I think this
Dryness
is
of eyes also.
dryness of eyes.
Dryness
Also.
of eyes,
Yes.
skin, and mouth.
Yes. So this is the Sjogren's system. And what is scleroderma? I think this is a patient may be having a musculoskeletal disorders also, like rheumatoid arthritis and other things.
There could be associated, but in scleroderma, it can be of two types, diffuse or limited.
Yes.
The skin thickness is there, and there could be esophageal dysmotility.
Yeah.
Or features of CREST syndrome could be there associated with it.
So you started methylprednisolone. Yeah. Now tell.
After looking at the literature, basically, then I started him on methylprednisolone. So initially he had a very good response. The glucose level came down to 162. I had to stop insulin, but there was progressive rise. On the second day, when I gave him methylprednisolone, again the requirement was low, but once the plasma glucose level again shooted up to more than 600 level, but then again it came down after increasing the doses of insulin to 25 units. Then, sir, because of suspicion of this Sjogren syndrome, I had sent this anti-Ro and anti-La antibodies. Complement levels were also sent, and a rheumatologist opinion was taken on that day. So anti-Ro and anti-La came out to be negative. Complement levels were normal in this case. And as the patient was having end-stage renal disease, there is very high risk of cardiovascular disease. Also, there was risk of developing infections if giving steroids to this patient. So the plan was made to start him on mycophenolate mofetil only 500 milligram twice a day, which was gradually increased to 1 gram after 5 days, and tablet HCQS, and steroids were withdrawn. We decided not to give him the steroids, and we will wait for the response of mycophenolate over the period of next 2 to 3 months. But so the basic thing was that after giving 2 doses of methylprednisolone, his weakness had improved tremendously. He was able to get up from the sitting posture. He was able to walk. There was decline in his acidity also significantly. So this weakness was not explained with uremic myopathy or diabetic amyotrophy both. So this both diagnoses were excluded after this. Patient was switched over to basal bolus regimen of 20 units Novorapid before breakfast and lunch and 15 units before dinner. Injection Degludec was continued with 25 units bedtime, and tablet linagliptin was continued in this patient. So my final diagnosis which was made.
slide हटा दो 2 मिनट के लिए. हाँ, yeah. So now I think 2 important discussions are there regarding the efficacy of methylprednisolone, which has improved the condition. What we see in the routine in most of the polyneuropathy or neuropathy, diabetic polyneuropathy also, what we have seen in some cases, it is inflammatory polyneuritis. And in those cases, our neurologist used to give methylprednisolone, and patient has so much of very effective pain relief. So is it the right treatment of giving in the inflammatory polyneuropathy the steroids, especially the methylprednisolone? Dr. Shailesh or Dr. Dariya or Dr. Rajnish?
Sir, if it is a inflammatory myositis or polymyositis, in that case, we can start the steroids. But if it is the amyotrophic, diabetic amyotrophic, I don't think so that it will improve. So if diagnosis is only the inflammatory, I think then we can start.
So
the
as Dr.
CPK
Ankit
levels
has
were
said
also
just now,
not that much raised, suggestive of myopathy in this case.
yeah,
But
Dr.
Ankit,
Ankit has just said that methylprednisolone only 2 doses give the immediate relief. Dr. Shailesh, what do you think?
Yeah, I think even if this was, even if you consider the diagnosis of amyotrophy or diabetic plexopathy, still steroids would be helpful.
Okay.
So even in diabetes, steroids help in such situations. These are some of the rare situations where despite diabetes, we give steroids.
In some cases, when the steroids were given in the diabetes case and the hyperglycemia is there, is it the aggravation of the hyperglycemia or it is the control of hyperglycemia? What do you think? Steroids?
Worsening of hyperglycemia?
Yes.
With steroids in this case, or you were talking in general?
No, in general, not in this case.
Yeah, in diabetic polyneuropathy or diabetic proximal myopathy, when we give steroids,
yes,
worsening of hyperglycemia occurs generally.
Yes.
That is there, and we have to increase the dose of insulin.
Yeah, but in this case,
the power was
I
not
have a
reduced
question
that
here.
much. It was only 4+. There was slight reduction in the power, which was not explaining his that he was not able to get up without support. So 4 plus power does not explain the patient complains that he was not able to get up. So the power was not that much reduced at his hip joint.
Why we did not go for that NCV, Ankit?
Sir, NCV was already done outside. He had this mixed axonal and demyelinating neuropathy. EMG was also done. EMG was normal, that was reported outside. Patient had underwent upper GI endoscopy 5 to 6 times in this case.
In that
And it
NCV,
was
what was the latency, FF latency? What was the?
that I don't remember exactly now.
So once your ANA was negative, then why you did again ANA?
Sir, I had sent ANA by immunofluorescence and immunoblot together, sir.
Okay.
At the same instant only, initially.
Yeah, Dr.
But
Shailesh.
because in this autoimmune profile, I had more suspicion of Sjogren's than scleroderma. Scleroderma was just a biochemical finding in this patient. There was no clinical finding to me. So I had sent this anti-Ro and anti-La separately.
Ankit, one question.
Yes,
This
sir.
patient required insulin in extremely high doses, requiring 800, 600 or 1000, maybe 1000 units
Sir,
per
I
day.
had given him almost 1100 units in a day.
Yes.
So in this situation, what was the, why did you use analog? You could have used simple regular insulin, which could be very cost effective in these patients.
Sir, actually, patient was on regular insulin since last 1 year. He had tried different types, and initially my thought was that it could be because of this regular insulin only. There are case reports that with regular insulin, there are chances of insulin resistance. Antibodies are formed. So I tried a different form of insulin in this case.
Okay.
He was already
Otherwise,
taking regular since last 1 year.
otherwise,
So that is
this
why I
is just a
started
message.
directly on Novorapid.
This is a general message for everyone that when we give IV insulin, it doesn't matter actually whether you give analog or regular insulin.
Yeah.
But I understand here the situation was different and you used it presuming that there might be some resistance.
Yes.
Yes, sir.
Yes. So first question was answered, I think, that methylprednisolone, usually indications for methylprednisolone is the inflammatory polyneuropathy usually. And in this case, very effective dose of only 2 doses of methylprednisolone improved his conditions absolutely like miracle, magically.
No, sir, there was not miracle. The plasma glucose after giving methylpred also raised, but the rheumatologist had suspected that if we will give steroids, he's already very immunocompromised. ESRD since last 4 years, uncontrolled hyperglycemia. He might develop some fungal infection or pneumonitis, and we might lose the patient in going in aggressive manner in treatment. So that is the reason we withdraw the steroids in this case, and we just went ahead with mycophenolate in this case, and we waited for the response.
And what we do understand about the Sjogren's system and this hydroxychloroquine is the drug of choice, I think. And mycophenolate we have already given. You have. So that might have improved the condition.
The drug of choice for Sjogren's is, I don't think.
Not drug of choice, but one of the drugs.
Yeah,
one of the drugs. Yes, sir.
Drugs, sir.
Yes, sir.
Not the drug of choice. Sorry.
But this
It is one of the
MMF is not the drug of choice, I think, is there.
Yes.
Sir, MMF, azathioprine, cyclophosphamide, HCQS, all this can be used, sir.
Yes, yes. So now please
So
go ahead.
Renal size of the patient was 69 centimeters. Right side, left side, it was 71. So biopsy was not possible. So there was an underlying suspicion that he might not be diabetic nephropathy as well. But we could not find the proper cause of the ESRD in this case. It could be this autoimmune disorder which has led to this nephropathy. So the final diagnosis which was made was type 2 diabetes for 10 years, diabetic nephropathy with end-stage renal disease on maintenance hemodialysis, hypertension, subclinical hypothyroidism, distal symmetric polyneuropathy, exogenous insulin antibody syndrome, and there were clinical and biochemical features in overlapping of 2 to 3 autoimmune disorder. So mixed connective tissue disorder was the diagnosis made by the rheumatologist.
I have little bit of thing regarding the diabetic nephropathy. I think it can be a non-diabetic nephropathy.
Yes, sir.
Because if would have been a diabetic nephropathy, the symptoms and signs and what you have already described is a little different thing. I think it was
Yes, sir.
autoimmune disorders which actually damaged the kidney, which is
Kidneys, yes,
my
sir.
thing. If other experts like all the Dr. Dariya, Dr. Rajnish, Pareek sir, Ramchandani, you want to comment?
Sir, this case is definitely very interesting and have multiple problems with diabetes. And you are absolutely right. It may be because of this mixed connective disorder can also lead to some renal problem. Probably maybe mixed either nephropathy with due to CTD, because this disease is definitely causing renal involvement. So I agree with you. It should be do some biopsy and confirm it whether it is diabetic nephropathy or some because of the mixed CTD.
Yeah.
So because of the small renal size, we could not do the biopsy. in this case.
Definitely,
Yeah.
I agree. You've done a lot of work in this case. That is really appreciable, really wonderful. Probably this much of diagnosis we have rarely seen so much of things here, and you are working with all the team with rheumatologists and all these things are high doses insulins with steroids and following the case. Really wonderful, appreciable, sir. Amazing.
Dr. Shailesh, what is your take? Dr. Shailesh, are you there?
Yeah, yes, sir. Sorry, I
Yeah.
was muted. Yeah, I
Okay.
think you rightly said if Ankit wants to publish it, then he will need renal biopsy report definitely.
Okay. And it is not a diabetic nephropathy. I think final diagnosis is I agree with all things except diabetic nephropathy.
Yeah.
Yes.
Why not diabetic nephropathy? He had such a big, such a high insulin level, hyperglycemia for a pretty long time. Why
Sir,
do you exclude diabetic nephropathy?
सर
And-
4 साल में सर उसके 4 साल में ही एक तो
पर सर ये देखिए ना आपकी 600 यूनिट इसको चाहिए पड़ेगी. How much insulin he required, and then after prednisolone, two pricks of prednisolone of 1 gram, his insulin requirement came down much less. What was the reason?
वो ये ऑटोइम्यून डिसऑर्डर था ना
तो,
सर.
हाँ, तो
तो वो उसने किडनी को डैमेज कर दिया था सर इमीडिएटली, और क्योंकि उसकी फंडस भी रेटिनोपैथी बाद में सिर्फ एनपीडीआर ही हुई है, इतना ज्यादा फंडस में भी नहीं था.
Disorder of kidney, sir. It may be
What about his urine report? I have not seen urine report. Albumin urine.
Patient was anuric. He didn't pass any urine. He almost passes 10 to 20 ml over a period of week. So I could not do any
You could have examined for
urine.
microalbuminuria.
It's a
Sir, I
unique
could not
case.
examine.
Right.
It's a very unique
Sir.
case, sir. As Dr. Ankit is saying that he was anuric since last 3 years.
3 years.
So almost since last 1,000 days, he didn't pass at 20 or 30 ml urine.
So that is why he was undergoing dialysis even continuous basis also, on daily basis also.
सर जब भी कभी रैपिड किडनी डैमेज होता है, यूजुअली डायबिटिक किडनी डिजीज में स्लोली डैमेज होती है. इसके अंदर 4 साल में उसके 3.2 क्रेटिनिन आ गया था और सडन डैमेज हो गया था सर.
सर
So
आपने ये
there could be
देखा
additive
होगा
factor,
कि
both diabetes as
patients
well as
में-
autoimmune.
Sir,
कि diabetic patients में कई बार there
Yes,
are
sir.
only a group of patients who develop nephropathy from diabetes.
Yes, sir.
It is not all the patients or total duration of diabetes. Many a times.
Yes, sir. ये जिनके हाई फैमिली हिस्ट्री पॉजिटिव होती है
Genetic-
उसमें
Family
genetic-
history is
में भी हो
there, sir,
जाती
in
है.
such
group.
cases.
या डॉक्टर शैलेश.
Sir, the point which I think is against diabetic renal disease is bilaterally contracted kidneys. Generally,
Yes.
diabetics will not have contracted kidneys. Either the size will be preserved, or in early stages, rather there may be renomagaly.
Rhinomegaly.
So I
Sir,
think,
but progressively after developing ESRD, progressively even in diabetes, so he had
Yeah.
this ESRD since 4 years. So
Yeah.
I thought ki it could be diabetic nephropathy plus added on autoimmune disorder. But what is the exact cause? Without biopsy, I could not make this out.
Okay. So I think the take-home message is very, very clear. You have given us such a beautiful case, and actually totally everybody was having their churning in the mind. What
Sir, I'll
it
just
could
share
be.
2 slides with the follow-up also.
Yes.
After 15 days, the patient had fasting plasma glucose of 114. Before lunch, it was 118, and before dinner, 232. Because of the suspicion of hypoglycemia, I further reduced the dose to 16 units pre-feed and degludec to 18. Linagliptin was continued. And after 15 days, I had done a CBC ESR levels. So ESR, which was 113 at the initial point when he came to me, had declined to 10 on the follow-up. Then after a period of 1 month, patient had developed one episode of hypoglycemia during dialysis. His fasting was 154, before lunch 128, before dinner 192, and after dinner 224. So again, the insulin doses were reduced. The patient keeps on following me. Every 3 days, he shows his SMBG chart to me. And currently, he's total taking 42 units in a day. Patient. So I'll wait for further 3 months in this case, and then I'll again repeat his insulin antibodies level, whether those become negative or not.
Yeah. Any other?
So
Yeah,
is he
this
continue on
then-
the HCQS and MMF, Ankit?
Yes, sir. He is on MMF 2 grams a day and HCQS 300 milligrams a day.
So, sir, I think take-home message is very, very clear that once you have the rapid damage of the, the kidney damage is there, and when creatinine was very high, I think the choice of oral anti-diabetic drug should be changed immediately. Metformin, like sulfonylureas, as Dr. Shailesh and Dr. Prakash has pointed out, that this is not the drug of choice. The linagliptin later on was given. So I think, and we have to think the non-diabetic kidney disease right from the beginning. That is I think, the take-home message. Dr. Ankit, what do you think? What is the take-home message?
Sir, whenever there is an hyperglycemia which is out of proportion to the clinical setting of a patient, we should always look for some underlying cause. Why the insulin resistance is happening, whether there is underlying Cushing's. Most common reason is the insulin technique is only improper. Patient is not taking proper insulin, there is no rotation of the sites, or there is some underlying Cushing's or acromegaly that is causing the severe insulin resistance.
Yeah.
So we should always look for an underlying cause, why the hyperglycemia is going on.
So last sentence by Dr. Rajnish.
A very nice, excellent presentation, Dr. Ankit. You rightly said that insulin technique is very important because commonest cause is wrong insulin technique used by patient. So rotation is very important, and proper cold chain maintenance and other insulin precautions should be should be very important to follow by the patient.
Dr. Daria.
Yes, sir. I think it's a nice case presentation, and it's a very good case that somebody is giving the 400 units in a day, then we think of something wrong with that. Either there may be an insulin resistance or some autoantibody. But
Yeah.
my take home message today is that if we see the history of this patient, that he went to the diabetologist, or we don't know whom he used to see, but every patient who comes to you, that should be keep on a protocol basis, that once in every year we have to go for a LFT, RFT, this CBC, the thyroid functions, the USG whole abdomen, to just keep watch on the your renal size. Then at the time of diagnosis, we should do a fundus examination as per the protocols. We should do in type 1 and type 2, then again repeat, and we should repeat the lipid profile. We should go for a urine on the day once if he is coming to you. So we should follow all these protocols, and according to that, we should use the RSSDI wagon wheel to start the treatment.
Yeah, Dr. Shailesh, sir. Shailesh.
Yeah, I think, sir, Ankit has presented it and worked up this patient very nicely, and we have discussed at length everything. One just small point I wanted to add. Ankit, what you have shown is a clear case of insulin resistance syndrome.
Yes, sir.
So I think if the time permits, is there any time or not?
Yeah, I think we can have
So
little
Ankit,
time.
can you tell us about insulin resistance syndrome, type A, B, C? In what category you will fit this patient?
So there are basically two types of insulin resistance, type A and type B. Type A are the genetic syndromes that we have, Mendel-Hall syndromes like this, and type B is the insulin antibody syndrome. So type B, again, there are two types of insulin resistance. One is the insulin receptor antibody, which is the major type B insulin resistance. Second is the insulin antibody. The directly antibodies are formed against the insulin. The difference between the two is that in insulin receptor antibodies, there is hypoglycemia in majority of the cases, and that develops basically postprandially 5 to 6 hours later. Whereas in insulin antibody, incidence of hypoglycemia is very, very less.
Okay, okay. Sir, I think Ankit, you have done a great job. Sir, Dr. Girish Mathur, sir, is here.
No, he is not here.
Okay.
Dr. Keswani is also not here
Okay.
because he
Yeah,
has some
I know,
urgent work.
I know. Yeah.
So,
So,
I
Dr.
think you
Pareek, sir.
conclude, or Pareek
Yeah.
sir is also some busy in some.
No, I'm here.
Oh,
here.
sir.
So
Sir.
I think I must compliment and congratulate Dr. Ankit for excellent
Thank you,
discussion, excellent presentation, and then excellent discussion. We still do not know till now. Again, after 4 or 5 visits, we could be firm on our diagnosis that what was the correct. But definitely the insulin requirement has come down dramatically, and we could found that it is definitely an autoimmune disease. So, but unfortunately, so it may not be necessary at the first consultation that we should get all the investigation, but at least we should write down all the investigation which are required, and we can get in on the next visit also, because patient is not all the time prepared for so many things at the first consultation from a general physician. So we can on next consultation or next visit, we can have other investigations, but at least creatinine or urine examination is very, very important with blood glucose or with a patient having a hypertension and diabetes, because kidney disease and atherosclerotic cardiovascular disease, lipid profile, these are 3 or 4 ECG. These are the 4 or 5 things which we should get it for the first consultation.
Yes, sir.
So that we can do not miss anything out of that.
Yeah.
So thank you very much, Dr. Ankit, and
Yeah.
excellent discussion.
Thank you, sir.
Thank you everyone for
अंकित को
your.
बहुत बहुत धन्यवाद और
हाँ।
आई थिंक सर डॉक्टर पारीक
प्रकाश जी
साहब
को भी
आज
धन्यवाद कि उन्होंने इतना अच्छा काम किया, अभी बनवाया, करवाया।
हाँ और डॉक्टर रामचंदानी, डॉक्टर शैलेश लोढ़ा, डॉक्टर दारिया, डॉक्टर रजनीश सक्सेना और सारी एक्सपर्ट टीम, डॉक्टर गिरीश माथुर सर, आई थिंक इस तरह के केसेस प्रेजेंट करने से बहुत आई ओपनर केसेस प्रेजेंट किया है और बहुत सारी सीख आज हमें मिली है सारे लोगों को।
Last question.
Yes.
Routinely what we are doing in the autoimmune diseases, that we used to give in RA or in scleroderma or some other the pulse therapy. So इसमें pulse therapy का कोई role है क्या sir? Like he gave only the tablet MPS, na, methylprednisolone. So can we give a 3 days pulse therapy?
Yes,
in that
I
case?
gave injectable methylprednisolone 1 gram.
Okay.
Injectable.
It was injectable given for 2 days, and the third was also I was about to give, but rheumatologist had stopped me.
Okay,
Yes.
then if it would be 3 days, then already it's a pulse therapy, right?
So
Yeah.
there
therapy
is
will be
basically an
interesting.
NIH protocol of giving pulse therapy of methylprednisolone for 3 days, and then we can give rituximab, cyclophosphamide to this patient along with prednisolone
Yes.
for this insulin receptor antibodies or this. But because he was ESRD and all high risk of infection, so we didn't give him steroids in this case.
So
Sir,
thank you.
one query from my
Yeah.
side.
Yes.
That is my personal query. We
Yes.
are using in India 40 IU, 100 IU, even 200 IU insulins in our country, because in high doses we are shifting the 100 and 200. I think in US market, more than 200 IU or 500 IU is also available. Dr. Shailesh, I think your comment.
Yes, sir. I think U500 is available in Western world from last almost 3 decades, and it is
Yes, sir.
predominantly used for severe insulin resistance syndrome, where the daily requirement goes beyond 4,000, 5,000 units in a day. So like leprechaunism is one such condition. Extreme insulin resistance associated
Yes.
with lipodystrophies. So these are the syndromes where the insulin requirement goes in thousands per day, and here they give U500.
Yes.
There in literature, requirement has gone to around 21,000 units in a day. The U500 was used in those cases.
Yes.
Oh, that's amazing.
So
And
shall
just
we
one more
conclude?
information.
Yeah. Yeah.
Just one word of information. U700, you might be knowing, will be launched in India very soon. Icodec. It is U700.
Yes. But
Next month.
उसका weekly insulin होएगा वो.
Yeah.
Yeah. So I think let us conclude the today's presentation. And इसके लिए तो सबसे पहले तो बहुत डॉक्टर अंकित को बहुत बहुत धन्यवाद, और
Thank you, sir.
सारे एक्सपर्ट्स को धन्यवाद, डॉक्टर पारीक साहब, डॉक्टर गिरीश सर, and all experts. Thank you very much. And shall we conclude? And shall we conclude?
Yes,
Yes,
sir.
sir.
Thank you, sir.
Yeah.
Yes, sir.
Thank you very much, and
Thank
good
you
night
very
to all
much.
of
Thank
you.
you, sir.
Good night.
Thank you, sir. Thank you very much. Thank you.